And the good news is it reduced suicidal ideation during the treatment period. The bad news is suicidal ideation peaked after they withdrew those hormones because you get that same sort of destabilization. And then we have this really interesting trial. I left out their days and their sort of methods because it was annoying to me that they altered day one of the menstrual cycle to be the LH surge as day one of their treatment protocol, rather than just moving things in a more organized fashion. But we still kind of get the idea here. When we put these pictures up, you can see that basically your LH surge is on the far left. That's where you have your spike in estradiol. And then you see the progesterone roller coaster. And this is the placebo condition, right? So it looks like a very normal menstrual cycle pattern.
Yep.
Then we go to the active condition where they introduced a transdermal estradiol patch, 0.1 milligram. And then they introduced oral micronized progesterone, 100 milligrams twice per day. And I don't think this is an actual draw of the blood levels, because you're not going to see the progesterone levels on blood work if you took them the night before. But this is sort of a simulation of, okay, now that roller coaster is leveled out. It's very smooth. And indeed, this did improve symptoms. This was a particularly ill population. They were, I think, identified from psychiatric facilities, and then basically was looking at their suicidal ideation, because that does tend to peak in this luteal phase for women, especially women with comorbid depression. Sort of a perfect storm, if you will. And the good news is it reduced suicidal ideation during the treatment period. The bad news is suicidal ideation peaked after they withdrew those hormones, because you get that same sort of destabilization. So we were looking at this and talking about this, and there's some things they could have done differently. It's like they pulled them out a bit early. And it's kind of not surprising that they got that same withdrawal effect.
Yeah, they could have added the estrogen a bit later. They also used a relatively high dose of estradiol, quite high for a replacement dose. So they could have used a lower dose, started it a bit later, so that the estradiol peak would have been graduated, if you will, just less in general, less peak, less of a trough when you withdraw. And they could have also altered how they replace the progesterone.
Yeah, perhaps with our pregnant alone in the morning, progesterone in the evening protocol. And if I'm looking at this, I'm not a statistician. We haven't run the numbers on it, but it looks like there's a much smaller area under the curve and a lower peak in both suicide planning and suicidal ideation. Definitely a lower net negative impact than the placebo group. So this is something that has published data that could potentially be used, and it's bioidentical. I probably wouldn't use that high of a dose of estradiol. It's questionable as to whether you even need that estradiol. Much more focuses around the progesterone and then the downstream GABAergic component of that.
Yeah, perhaps they use the estradiol just because at least the guidelines today tend to say combined estrogen and progestogen replacement has better evidence than progestogen only. So now people are hesitant to study progestogen only.
Yeah. And we talked about agmatine earlier, and some people probably thought we lost our marbles. But what do we know about agmatine and PMDD, specifically in a rat model?
Yeah, in progesterone withdrawn female rats, which is a rat model for luteal phase or PMDD rats, it enhanced the marble burying anxiety. Not exactly sure how they measured this or how much carry over it has to human data, but it's certainly very interesting. Also, immobility time. This was attenuated significantly by agmatine, which does have effects on glutamate and NMDA receptor activation. I believe it's specifically an NMDA receptor antagonist. I know that there's a very rare autoimmune condition, which is you form an autoantibody to the NMDA receptor, and it can cause psychosis and hallucinations, etc. So this is glutamate is tied into NMDA activity. That's why we mentioned monosodium glutamate, and agmatine can help attenuate this as sort of an antipsychotic, but without being a direct dopamine receptor antagonist.
Yeah, and this is something that is actually in a number of pre-workouts. So I wouldn't be surprised if there were a number of women who started working out and using a pre-workout, and then noticed that, hey, the exercise helped my PMDD, which it certainly should, but also maybe the agmatine is sort of an added bonus there that's also helping to stabilize things. As far as the safety profile, because that's what we always have to ask ourselves when we're looking at any kind of treatment. It's been studied for 3 weeks at fairly high doses, I believe in the 2 to 4 gram per day range, which is a very high dose, in like neuropathic pain and in conditions that are similarly related. And then there was a self-published study that was really interesting. Individual, they had been taking it for 5 years at a dose, I think between 2 and 3 grams per day. No abnormal, physical exam findings, blood chemistry findings, et cetera, with their primary care. Again, not a whole lot of measurement being done there, but, it seems to speak to at least being something that would be safe to be used. And you could probably use it cyclically as well. You don't necessarily need it, 31 days out of the month.
Yeah, definitely another good adjunct option.